Hello, my name is Rebecca Puchkors, and I am with Maryville University, and I am presenting my project for the DNP program, Implementation of Intimate Partner Violence Screening during Medical Forensic Exams to Identify and Connect Survivors with Resources. My DNP chair was Dr. Wunderlich, an amazing person who helped me through this project with the Catherine McCauley School of Nursing, the College of Health Professions, and Maryville University. I wanted to just give you a little bit of a background in some of the statistics and things that prompted us to implement this project. So the CDC has published in 2023 some new statistics surrounding intimate partner violence or domestic violence. And we know that 41% of women and 26% of men have experienced sexual contact violence, physical violence, or stalking by an intimate partner during their lifetime and reported a related impact. And we know that many of the incidents that happen are not reported, and these are just the ones that are. So the numbers are probably even higher than this. 61 million women and 53 million men have experienced psychological aggression by an intimate partner in their lifetime. And this is linked to trauma, abuse. It has been linked to homicides and resulting in homicide, and has been linked to sexual assaults, including those by unknown perpetrators. 16 million women and 11 million men have experienced intimate partner violence before the age of 18. So this is not just an adult issue. Often we think about this in terms of adult relationships, but this is actually starting to happen in our young children, early dating experiences, junior high and high school as well. Intimate partner violence also increases the risk of individuals for experiencing sexual assault. And we found through our literature search that they often go hand in hand. So that prompted our research question: will intimate partner violence screening at the time of a medical forensic exam help to identify survivors and connect them with resources? We did a search in the literature through Maryville University using a couple of databases and some keywords like intimate partner violence, screening, sexual assault, medical forensics, and domestic violence. We also used combinations of intimate partner violence and sexual assault, or intimate partner violence and screening, so that we could come up with as much as we could find out there, looking at screening for intimate partner violence, looking at interventions for intimate partner violence, and looking at the connection between intimate partner violence and sexual assault. And some of the themes that we came up with were common risk factors that were associated with intimate partner violence. We came up with a variety of screening tools that were being used to screen for intimate partner violence, with a variety of results and validity as well, and several interventions for intimate partner violence to help not only with the prevention, but also the support and promote more positive outcomes in helping survivors of intimate partner violence. We also noticed some gaps in our literature when we were looking. While there were many screening tools out there, there was definitely a lack of a validated screening tool that was being used consistently in a variety of settings. And in some of the studies, there were no screening tools at all. They just weren't using them, or they were organizations were using a homegrown scale or questionnaire that they had just created themselves and hadn't validated for use in any sort of setting. We also saw in the literature that many of the studies that were done on screening for intimate partner violence or interventions for intimate partner violence had a very small sample size. And that was difficult because it was hard to look at how that could be replicated or applied to different settings to see, was it a reliable study? Was it helpful? In some of the studies, we just looked at screening and they just implemented a screening tool, but they didn't follow it up with any sort of intervention. And a lot of times they didn't follow up with the participants beyond that specific encounter in administration of the screening. So we didn't have any idea what happened, if they were connected to any sort of interventions or resources, and kind of what happened in terms of outcomes for them along the way. And there were limited studies, although there were some that were significant, there were not a lot of studies that have been done connecting intimate partner violence with sexual assault exams. And I just wanted to review a few concepts and definitions. So intimate partner violence is abuse or aggression that occurs within a current or former romantic relationship. And this is a CDC definition. Oftentimes we call it domestic violence as well, but it doesn't necessarily mean that it's somebody who's living in the household with them at that time. So intimate partner violence is really a more broad and appropriate term. Sexual assault nurse examiner, or SANE, is a specifically and specially trained registered nurse who collects evidence for sexual assault as well as assesses the survivors of sexual assault. Sexual assault is any sexual contact without consent, and that doesn't mean solely intercourse. It could be any form of sexual contact without consent of the person. When we refer to the HITS tool, we're talking about the Hurt, Insulted, Threatened, Scream tool. And this is a screening tool that is used to identify risk for intimate partner violence. When we talk about a medical forensic exam, this is a head-to-toe exam that is given by a SANE nurse typically to assess the survivor for any injury or needs and to collect evidence and provide interventions to help promote ongoing health. We did use a theoretical framework for this project, and this came from Bandura. It is a social cognitive theory, which is a theoretical framework that helps to connect education, social influences, and health behaviors to help kind of guide nursing research in a way that we can change our interventions and our processes in healthcare to promote better outcomes and to serve people in a better way. We had some methodology for this project. When we came up with the steps for this project, we had 6 steps that we needed to complete. First, we oriented the screening tool and the process for implementing the intervention. We oriented our SANE nurses at a monthly staff meeting so that we made sure that everybody was familiar with how to administer the tool, how to score the tool, what to do with the tool, and what the project was for. And this ensured consistency and buy-in from our nurses. All adult survivors that presented to our Community Advocacy Center were screened for intimate partner violence with our Hurt, Insulted, Threatened, Scream tool, our HITS tool. If that screening was positive, then the survivor would be given a list of predetermined community resources and several options for shelter and safety to help them with intervention. The sexual assault nurse examiner then places the completed screening tool into a locked box in the clinic manager's office, and a retrospective review of the electronic medical record will be conducted based on the months needed to collect the 50 screening tools to match our 50 post-intervention screening tools. And the project will determine our need for universal screening to be implemented and added to our electronic medical record. The design of this project took place at a community-based advocacy center that serves several counties within the community, providing medical forensic exams, legal advocacy, peer advocacy, and counseling services for survivors of sexual assault. Typically, the people that present to the community advocacy center are adults 18 and older. We also included a retrospective review of the electronic medical records for participants so that we could have a pre and post intervention comparison. Our inclusion criteria were adults 18 and older presenting for a medical forensic examination for sexual assault within the past 5 days. And that is because our criteria for collecting evidence and doing that exam is that it has to be within 120 hours of the sexual assault. Exclusion criteria, anyone over 90 years old, those who were unable or unwilling to consent to a medical forensic exam were excluded, and those participants that had already, or those survivors that had already completed the HIT screening tool within the past 3 weeks, specifically if they had been in for a medical forensic exam within the last 3 weeks and completed the tool, we excluded them as well so that we could make sure that the data was accurate and that we weren't having any sort of memorization of the tool or duplicates of data that might affect our results. We did look at the CDC's recommendations for screening tools for intimate partner violence, and they had a long list of them listed out with their sensitivity and specificity listed, as well as the patient populations that they had been trialed in or validated for. And we picked something that worked in outpatient settings, emergency rooms, and primary care that was also validated with multiple populations, male and female, and that it was a short tool that would be pretty easy to administer. It could either be clinician administered, meaning the nurse asked the questions and the survivor answered, or we could hand it to the survivor and they could answer the questions. And we wanted to make it very easy and straightforward. This tool also has a sensitivity up to 100% in identification and specificity of 86 to 99%. So it was a very strong tool in being able to be reliable and getting the information that we needed and knowing that the results were accurate. We determined that a score of 10 or greater on this tool equaled risk for intimate partner violence. And then we went ahead and added some demographics at the top and some resources at the bottom that would be provided if somebody scored highly at risk or 10 or above. We were lucky in that this project was pretty low budget. We really just needed some staff training that we did at staff meetings. So our cost was just our hourly cost for the staff meeting for the nurses to do the training, and then some supplies like paper and pens to be able to make copies of the tool and for people to complete them, and then the amount of time to complete the screening as well. The lockbox to keep the data collection screening tools in, and just some refreshments because nurses always appreciate having some snacks while we're trying to get their buy-in for this project. We did want to make sure that we were ensuring the protection of human subjects for this research study. We made sure that there was no identifying information on any of the surveys. They were de-identified. We did not put any information on them at all about the patient that was identifiable. We kept them stored in a locked box that was also locked inside the clinic manager's office. We did complete a retrospective review, and that was provided by our clinic manager who gave us medical record numbers, and we kept that list stored in the locked office until we completed that review. All of the data was de-identified for documentation and analysis. Confidentiality was protected for everyone involved, and then we will be destroying this data after 3 years per our protocol. So we looked at our pre-intervention retrospective review of the records. Using a Plan, Do, Study, Act model, we implemented our intervention and then looked at our post-intervention data as well. And we used a z-test of the difference of two proportions utilizing the SSPS software version 29. So when we compared our pre-data and our post-data, we wanted to use a significance of 0.05 and do that z-test for the difference of the two proportions. Our independent variable is the intervention data pre-intervention and post with that retrospective review of the records, and then the dependent variable is actually the screening that occurred. We also looked at some results of demographics that might be helpful for future considerations. And we noted that the majority of our patients were really under 45 years old, between 18 and 45 years old, with a handful of them 46 to 60 years old. Vast majority of the survivors or the participants were female, but not all of them. And about half of them were Caucasian, and then another third Hispanic, and the remainder Black or other. When we looked at the scores from the screening tools, we had scores ranging from 4 to 20 and a mean score of 11.02 with a standard deviation of 5.63. We noted that 32 of our participants screened positive, so 10 or more on that HIT screening tool. And so that's 64% of our participants that screened to be at risk for domestic violence abuse. You can see here that our level of significance and our hypothesized difference, and then our pre and post intervention sample sizes were 50 participants for each, with the number of positive screens being 32 in our post intervention. So 64% of our survivors or participants screened positive for identifying risk of intimate partner violence. And then we were connecting them with resources. And we also looked at what resources we were connecting them with. This will help us in the future know where we need to put more resources, maybe look at funding and what else is needed to help people. But most of the participants that were identified to be at risk were provided the hotline number for domestic abuse. They were also provided a list of resource centers like women's shelters in the area, and they were given a referral for counseling as well. Significant number, 60%, we had to notify the police per the patient request. And then we also did contact family members and shelters with our participants' permission as well as an intervention. So again, we had some pretty significant results. 64% screened positive for intimate partner violence, and we noted that that comes with a 95% confidence interval that this would be repeated and we would get the same results if we were to do this again. So this really supports our need for universal screening. Currently, we are not screening for intimate partner violence anywhere besides the Advocacy Center for Adults, and we often do exams at many locations, including outpatient clinics, college campuses, emergency rooms, and we see all ages, pediatric and adult population. And so this really does support our need to be screening all of our survivors because, like we noted, 64% of them screen positive, and we have an opportunity to be able to help them. This allows us also opportunities to invest in additional programming and growing our intimate partner violence or domestic violence program so that we can address the need in the community for that as well, even separate from our sexual assault exams. We can use this information to apply for additional grant funding to help grow those programs, to help train new nurses and staffing, to help get supplies that we need to be able to do domestic violence exams, and to work with our community to develop more resources that we can refer people to help support them if they are identified to be survivors of intimate partner violence, as well as working with our law enforcement agencies and forming those connections to really be able to impact and promote better outcomes for people. So in conclusion, identifying survivors will help us to create opportunities for support, resources, safety, and health prevention. And so we really need to be incorporating this validated screening tool during all of our medical forensic exams so that we can ensure that screening is happening when the survivor is vulnerable, but also when they're there with us in this very private, therapeutic, and trusting setting, building that rapport so that they're able to disclose to us things that would be very difficult to disclose, and we're in a position to be able to help them, link them up with things that are going to be supportive and provide for safety, in addition to being able to implement this tool in even younger populations starting at ages 14, because we know that this doesn't just start in adulthood, but it's affecting our young people as well. And these are my references for the project. Thank you very much.